Where are you seeing the most success?
We have really expanded the capabilities of our facilities. We've leveraged some of what we do really well here. We're one of the largest trauma centers, the only level 1 pediatric and adult trauma center between New York and Montreal. So we serve a lot of people. As we brought other hospitals into our fold, we now have 5 trauma centers. The one in Westchester is a level 1, which is the super highest level. The other 4 are all serving their communities closer to home, shorter ambulance ride away. You're just going to get a really high quality trauma network experience with really vetted surgeons and evaluations. And that part I think we've done really great in. And now Westchester's network, we have 5 of the 44 trauma centers in the entire state of New York. We represent more than 10% of all the trauma capability in a state of like 17 million people, which is pretty amazing.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right. I am joined today with David Lubarsky, who's the president and CEO of Westchester Medical Center Health Network, former CEO of UC Davis. David, welcome to the Scale Community Analyzing Healthcare podcast.
Thank you very much for the invitation to be here.
So I want, for the benefit of our guests, to just quickly frame what WMC Health is, Westchester Medical, but please correct my very quick summary description. So it's a nonprofit safety net academic healthcare system headquartered in upstate Hudson Valley, New York, 10 hospitals, including a children's hospital and a behavioral health center, a very well-known major hospital, Westchester Medical Center, 1,700 inpatient beds, or I'm sure that number has changed recently, 12,000 employees, 3,000 attending physicians. So what I think of when I think of the Westchester system is a very significant operation, a microcosm universe unto itself, lots of moving parts. Is that fair?
I think that's a great description. We are an essential and indispensable part of the entire healthcare ecosystem of a very large swath of New York State, up and down the Hudson Valley. You can throw a stone and can't fail to hit some hospital system in New York City. But as soon as you leave those environs, if you want a level of advanced care equivalent to what can be found in the city, the only place to find it between New York City and Albany is at Westchester Medical Center and its community hospitals.
I think I read somewhere that your footprint, your net, covers over 6,000, was it 6,000 miles?
68 miles, yep.
Yes, square miles. So really expertise in how to cover a lot of terrain. How large is the population within that terrain?
Several million people. And, when you think about the fact that, we're serving just in our system more than 400,000 individual patients, 60,000 admissions to our hospitals, and, a couple million outpatient visits. I mean, it's pretty gigantic.
Enormous. So included in that, community hospitals, stroke centers, skilled nursing, assisted living, home care, mental health services, and obviously telehealth. So just the range of offerings grows and grows, and with it the complexity. So that gets me to my first question. So you played similar leadership roles at Duke, the University of Miami, UC Davis. What's similar about WMC and these other institutions, these other systems? What's unique and different? And also maybe from a job comparison, how does this job differ? And how is it more of the same?
Right. Well, so in terms of the comparison, it's very interesting. Those organizations are all, unique in their own way and very similar in that, they're level 1 trauma centers. They have large concentrations of pediatric services, burn centers, and organ transplant centers and ICU meccas to, where the most complex patients get sent. One of the things that's unique about Westchester, though, is we get more inbound transfers than virtually any other hospital in the United States, almost 14,000 inpatient transfers into Westchester. And that compares to UC Davis, which was in a similar place. It's the only academic medical center, a very wide swath of Northern California, nothing between San Francisco and Las Vegas. The only thing there was an academic center was UC Davis in Sacramento. But we only got like 5,000 or 6,000 transfers inpatient a year. And Westchester gets more than twice that because the number of areas that count on us to do things that only a major tertiary center like ours can do is very large. So that's one thing.
Before you move on to the next
Sure.
similarity, where are most of those transfers coming from? Are they coming from a single upstanding community hospital, an urgent care center, a primary care practice? What's the primary driver of those transfers?
Well, we have 6 acute care facilities and 3 subacute care facilities.
Okay,
right. So that's together they comprise the largest, but the single largest referral source we have is a system that doesn't belong to us. They're just partners. We help them sometimes staff some of their services. They send us, there's one system that sends us almost 1,800 of those 14,000. They're the largest. But what's most interesting is even our quote unquote greatest competitors in our own space, in our own communities, because we're not the only hospital in some of these areas, they send us stuff too, because frankly, there's no pay. Yeah, well, they don't have it because they're running some community hospitals, but their referral centers are either on Long Island or in Manhattan. They're not in the Hudson Valley where Valhalla, New York is, where Westchester is. So we're the recipient, unless you really want to travel another 2 hours to go the 20 miles into the middle of Manhattan, right? You don't want to actually have you and your family be transported there for complex care. So we get a lot of patients from Montefiore, from Northwell, from NYU, from Columbia, who are quote unquote our competitors, who are trying to provide services in our region. And they're doing, it's not like they don't provide good services, but they don't have the breadth that we do of a complete health system in the area of their hospitals in this region.
You're the giant in that region and get the derivative benefits. Makes sense.
Exactly. Yes.
So I want to ask you a question I've always wanted to ask a health system CEO on a podcast. So today my dreams come true. So you have this large system and it's a puzzle with various pieces that are all theoretically, conceptually supposed to fit together. To what extent do they fit together? Do they synergize with each other? To what extent are they independent? To what extent do they create constraints and diseconomies, friction with each other? And let me list them. Community safety net, academic center, clinical research, the many hospitals, behavioral health, I think inpatient, community hospitals, skilled nursing, assisted living, home care, and telehealth. That's sort of the puzzle that I see in front of you every day. Does that make like a concert, like a beautiful sound? Is it like Mozart? Or is it more like heavy metal?
It's more like a junior high school band attempting to play a Mozart symphony.
That's a great metaphor. Well done. Walk me through that. Unpack that for me.
Tuba player and pianist. Growing up, I grew up actually in Westchester County, and I can tell you it's not that easy to get everybody to play in tune. However, that actually is the challenge here, and one of the things that I'm really enjoying, which is we've been more of a holding company, meaning people needed help, they needed our support, we brought them into the fold, but we weren't an operating company where we were truly systematizing each and every aspect to its optimized function. And that's my goal, which is to turn us into a true operating company where we're doing the same thing the same way, not always exactly the same because each hospital is slightly different. But, I'll take an example. I was reviewing all the safety procedures because I had to take an in-service on the computer, right? Because every new employee needs to do that. And I was reading that there were like 3 different phone numbers across our 9 facilities. I don't know why 3, but there were only 3 different phone numbers across our 9 facilities if there's an active shooter. And I'm like, that should just be like, we should pick a phone number, right? And that should be the phone number that everybody knows. And nobody has to think which facility I am in today, because some of our doctors and our residents and other people, they travel back and forth between facilities. And it's that very simple example about how do we order things? How do we handle inventory? What do we do about our peer review processes where we're validating and guaranteeing the high quality of our physicians to a man or woman, because there's 1,000 of them, right? And they're spread out across all of our facilities. How do we make sure, right, those that are employed by us are great? And what are our processes for the other 2,000 physicians who work in our places but aren't employed by us? How do we deal with that? Each place has its own way. They're all good ways, but they're not all optimal, and there's certainly not any synergies where we can say, oh, we have a process, we've automated it, now we only need one person for all 9 facilities instead of 9 people for 9 facilities. So we have some work to do around that systematic optimization. And I'm very excited. I love doing that stuff. I'm an operator at heart, and I was a professor of management science I was at the University of Miami for 16 years in the business school, and also a professor of business at Duke. Before that, I love this stuff. So for me, it's sort of like mom and apple pie.
You have to imagine that the job is never done. There's always more that could be standardized, especially as the network is dynamic, right? It's evolving real time. So the chase between the hare and the coyote continues. The network expands, the need to standardize expands.
Right.
So thinking about all those different puzzle pieces, which of those pieces do you think is today benefiting the most from your system, from your network? Where is it which instrument is making the best sound? Is it the hospitals? Is it the outpatient network? Is it the digital expansion into telehealth? Where are you seeing the most success?
Well, right now, and this is just based on, traditionally health systems were hospital-centric. This system was no exception. And to that end, we have really expanded the capabilities of our facilities, and we've leveraged some of what we do really well here. And so, for example, we're one of the largest trauma centers, and one of the only level 1 pediatric and adult trauma center between New York and Montreal. So we serve a lot of people. But what we did is we said, as we brought other hospitals into our fold, we now have 5 trauma centers. Only the one in Westchester is a level 1, which is the super highest level. But the other 4 are all serving their communities closer to home, shorter ambulance ride away. So if you don't have to be airlifted in here, you don't have to come here, you're still going to get a really high quality trauma network experience with really vetted surgeons and evaluations. And that part, I think we've done really great in. And now Westchester's network, we have 5 of the 44 trauma centers in the entire state of New York. We represent more than 10% of all the trauma capability in a state of like 17 million people, which is pretty amazing. That's a really hallmark thing where people know, no matter where they are, they want to come to Westchester because we're the only ones in the entire area that are running this level of trauma.
And as you think about that whole infrastructure, that whole portfolio of solutions, and you have trickling through it the concept of being a safety net nonprofit that is supposed to provide care to the most disenfranchised, how much operational complexity does that create for you? I know we're about to receive, the estimates are plus 10 million people to be excluded from Medicaid. As you try to manage budgets, and are you cross-subsidizing? You must be from one asset to the next, from one department to the next. Are you squeezing the arms of your benefactors and explaining to them what the implications are for your budget going forward? Are you working with your payers to try to offset some of the coming wave of unfunded patients? How much of your day is spent just dealing with the reality that you are a safety net system?
The first 24 hours of every day I spend on that.
That's funny.
The next 24 hours, right, because I'm multitasking, I'm spending on everything else. That does occupy a great deal of effort. Where, what a lot of people don't realize is that, healthcare is big money, but it's not big profits, right? I mean, we are barely skimping by. Our organization lost a lot of money last year. We've turned it around. We're almost at break even this year. We should be at break even by early next year. There's no cash in the bank. There's no secret Bahamas bank account. There's no, right? And further cuts are just going to degrade our ability to continue to keep our doors open to all who need us with reasonable access, right? When you run out of money, what happens in England? The queues go up, right? And the lines to get in, and it takes years to get an elective operation. We don't want to be like that. And so we're doing everything humanly possible. One of the things I'm preaching these days is civil obedience, which is very different than civil disobedience. What does civil obedience mean? Well, we can help identify and help coach people through staying on their Medicaid rolls,
Mhm.
despite all the attempts to throw them out. A lot of the expected disenrollment will be because people don't qualify, they can't prove their work experience, they don't get their mail, they don't realize they didn't resubmit their qualifications at the 3-month or 6-month period or whatever the new law is going to be. We can help with that. We know who they are. We know if they're certified in Medicaid, right? We have the ability to do that en masse, and we can offer support systems the same way we did to vaccinate the community, right? We vaccinated the community against COVID. We can vaccinate the community to a certain extent with our help against being inappropriately disenrolled. That's very different from civil disobedience. That would be like not obeying the law or going outside of an unjust law. Here we're just saying, we're good. Get rid of all the fraud, waste, and abuse. We're with that. But there are many, many people who are going to be caught up in the web of those extra requirements who don't deserve to be thrown off. And that actually is probably the majority of the financial impact. So we can do something together, right, at scale, right, that helps our communities and sets the healthcare systems up to do what they should be doing, which is preserving the health and access to healthcare for every human being that we can.
We interviewed recently a CEO of one of the 150 HCA hospitals, and she made a point of highlighting to us that despite the for-profit status and reputation that HCA and other groups like it have, they're just as much a safety net. They're obligated to provide charity. There's a lot more similarity between the for and the non-profit than people might assume. Do you agree with that? Or do you see a significant contrast?
So they're not quite as open door as a place like Westchester, but some of our fellow New York systems are not as open door. I mean, you need care. It doesn't matter. Part of our mission statement is we're here to care for you regardless of your ability to pay. We're here to take care of you because somebody should, right? As a society that cares about all its people, right? There needs to be places like Westchester. Having said that, the country has decided that despite all of the bills and the laws and the enrollments, healthcare is a right. If you walk into an emergency department, even if you're a for-profit hospital, you've got to take care of that patient. Now, you don't have to provide them with follow-up elective hip surgery if they're complaining of hip pain, right? If you come to Westchester and you got really bad hip pain and you need a hip replacement and you can't pay for it, we're still going to do it, right? So to that extent, we're different. But in terms of the emergency care, we have decided that that's a right. And now what we're doing is we just simply have undercut the funding for that right. We've said, a lot of people no longer have Medicaid, so that you got to treat them anyway for nothing. A lot of people won't qualify for their ACA subsidies, so they're going to take a chance and not have insurance. They're going to show up in your ED. You got to take care of them anyway, and they're not going to be able to pay their bill if don't have enough money to pay their no longer subsidized ACA healthcare stuff. So we basically have just done a giant cost shift to the EDs of every hospital in the United States, and most importantly, to the ongoing care of those patients at safety net hospitals like Westchester.
What do you expect to happen as a result? Increased denial of care, chaos?
I think it's going to be harder, and there'll be some rationing unintentionally. It won't be overt, that we'll be like, well, we can only do 10 hip replacements for free every month or 20 for free every month. Because at the end of the day, we're not making that money. The hip replacement people with the hardware are making that money, right? I mean, it's not like, you guys should just do it. It's like the personnel issues, of course, you still got to pay people, but you also have to buy things, right? And you've got to pay nurses to take care of the person post-operatively. It's not as simple as just saying, well, won't you please just do this for free?
Yeah.
So that's where I don't know.
You were in North Carolina, you were in Miami, Florida, you were in California, dealing with these issues. A big theme of mine is highlighting contrasts across state lines in things like Medicaid coverage and funding and interpretations of safety net, access to care. And you do see in the data wide variance from one state to the next. How would you compare Florida to New York to California from a CEO of a hospital system perspective? So when it comes to this topic, safety net.
So I've worked every single place I've worked since Duke University, which wasn't really a safety net per se because the University of North Carolina was just down the road. And there also was a county hospital down the road that didn't do that much county work. Now part of the Duke system called Durham Regional. So they didn't do quite as much safety net. They still took care of a lot of poor people, believe me. But the last three places I've worked, in Miami, in Sacramento and now here in Westchester. About 40% of the patients in the hospital have Medicaid or no insurance at all. And that varied a little bit. But in Miami, there was a public tax that went to support the county hospital in the provision of free services. That was Jackson Health System. I worked there and the University of Miami. They were joined together as more or less a combined organization. Not exactly, but mostly. That worked really well. So that even if you didn't have Medicaid, we had a lot of immigrant populations that didn't qualify back then, probably still don't qualify now. There was a public tax to support that. And so there were services up to the amount of the tax pretty much that went to support that community. If there wasn't enough, there were queues, right, to get that type of elective care. The emergency care has always been available. Same thing at UC Davis, right? We were about 40% inpatient Medicaid, and we took care of everybody who needed to be taken care of in the region. And we formed partnerships with all the community clinics and the outlying rural hospitals. I'm doing the same thing here at Westchester. At the end of the day, there's only so much money to go around to pay people to provide services. And we're going to have to come up with social support systems because even Medicaid only pays about 40 to 65 cents on the dollar, depending on what state you're in. How do you make that up? Well, you make it up on commercially insured patients. Now we're cutting the rug out from people who were getting Affordable Care Act subsidies, which was commercial insurance. So we're losing the cross-subsidization, we're losing the direct payments, and we're doing it with like 50 cuts to a slow death, if you will, because they're phasing these in. So it's not like there's a sudden cliff. And so people will be adapting by actually decreasing the level of niceties, the level of services, the level of reinvestments in their capital buildings, right? You can go 3, 4, 5 years, right, and not put in new air conditioning and not buy a new chair for your waiting room and, not putting in a new ventilator and using the old ventilators. But in the long run, that hurts the entire population of the United States of America by not having their health systems have sufficient revenue to reinvest and to modernize what they're able to offer the entire community. So I think this has been very short-sighted, and we're going to have, I hope, a day to address a sort of redirection of where we're prioritizing funding in the federal government to further support Medicaid and Medicaid expansion, because otherwise we're just going to have a disadvantaged, underserved population.
So if I was to, and I know we are limited in time, so I have to be incredibly efficient. I have 50 questions to ask you in 4 minutes. So I have to prioritize. If I was to list for you themes like automation, transition, ever larger transition into digital, virtual care, the ever greater role of uniform data in creating an opportunity for outcomes-based care, which leads into value-based care, the opportunity to imagine completely new procedures tackling chronic systemic issues like cancer, heart disease, stroke. What themes am I touching on? How would you prioritize these themes based on what you're most excited about over the next 5 to 10 years? Where's the good weather that you're relying on that you think will make your job and your system happy or happier place over the years to come?
Well, sometimes a crisis is good in the sense it really makes you say, okay, we can't continue to do things exactly as we've done them because there will be insufficient resources for that. And I think this will actually help drive AI adoption across the organization. And by that, I don't mean that we're going to give up taking care of patients to machines. But what I am going to say is that AI should be called not artificial, but augmented intelligence. What we need as a nation is a carefully curated large language model for medicine so that people accessing it can count on it to give them honest, non-hallucinogenic recommendations. Once you do that, nurses can start to do more of what, say, an advanced practice nurse does. An advanced practice nurse can do more of what a primary care doc does. A primary care doc can do more of what a subspecialist does. And there'll be enough doctors to go around, enough care to go around without impacting anybody's job. So I think this is really important because access and the ability to access care and the ability to provide care to uninsured populations, which we're going to be forced to do, could be fit in if we increase the efficiency of each person providing that care.
Do you think that the role of CMSI, the Innovation Lab, all the risk-based, patient stratification orientated progressive and some would argue very complex reimbursement programs that have been launched over the last 15 years, including that Medicare Shared Savings, Medicare Advantage, all the ACOs, everything ACA related. Do you think that competes with what technology might be capable of in terms of reshaping our healthcare in a very positive way over the next 15 years? Or do you think that will have a lesser influence?
I think
In
that's
other words,
analogous.
let me put that in short form.
Yes.
Can pricing only do so much?
Pricing can only do so much. I mean, and especially when you're playing around the fringes, most of the some value-based arrangements have very large upsides and downsides. Most are playing around at the fringes, right? 1%, 2%.
And we
up,
see that in the
down.
numbers. 15 billion here, 5 billion there.
Right. That's not going to get us anywhere. I mean, we really, there are ways to do this, but, at the end of the day, right, we have all these different layers of people basically taking a bite out of the dollar, right? There's insurance companies, right? I mean, they take a lot of money out of I think about 15%, right? That's their medical loss ratio acceptable profit, right? Well, that 15% a lot when you're talking about $3 trillion. That's enough to restore all of the Medicaid cuts and more, right? So if you disintermediated, I hope they don't yell at me, but if you disintermediated insurance companies, why is it that you need an insurance company? Actually, you could do a rating of a patient's risk and an appropriate assignment for that and pre-authorization. AI can do all of that. Right. So when you think about what are the administrative functions that will deliver large savings, those are there, right? As well as making sure that we're not doing care that doesn't need to be done. AI can also help doctors stop giving care that's not indicated or make them double think about it. That doesn't happen that often, but very often we bring patients in and we spend a lot of time and therefore money in checking people and saying, hey, you're okay. Continue your medication. Or, hey, your blood pressure is a little high. I'm going to make a simple algorithmic decision to increase your medication dose by, 10%. You really don't need a doctor to do that, right? A nurse and an algorithm can take care of all that. That's already been shown to work in diabetes management clinics. We can do this for many, many other things where, again, we're freeing up the highest paid individuals in the healthcare system to operate at a much higher degree of impact.
So you're
right?
looking at a significant injection of additional resources through technology.
Yes.
Which we should all be excited about. Do I still have you for 30 seconds or you got to go?
You sure do. Yes.
Okay.
You tell me when I can leave. I have, 20 people waiting at the door, but they can wait for you.
Last question. I promise. Last question. CVS announces a number of health system partnerships where it's going to use its stores, in-store clinics to provide primary care capacity. And supposedly this is very good news. We'll see whether it outperforms or not. Walmart and Walgreens go in the opposite direction. They're doing less and less. What are you excited about in terms of what's possible vis-a-vis strategic partnerships that you see out there that you think you might participate in over the years to come?
So for patient stickiness, if you will, that is, they want to continue to use you. They use you because their doctor trusts you and says you should go there if you have a complex problem. So that works if CVS is a partner to a particular organization. If they're not a partner to a particular organization, then there's very little benefit to the health system itself. So people will be looking to corner that part of the market. Primary care usually requires a fair amount of subsidy in order to break even in a health system. So if someone else is willing to bear that burden and you get the referrals downstream, that's a super win-win for health systems. The thing is, they're not going to be employing doctors, right? Their primary care is going to be delivered by advanced practice nurses. And if they're AI enabled, as I said, that's probably okay. And they can, if it's not like they're the last stop, there should probably be a bilateral relationship where we're ready to stand and help and advise that clinic, right? Either with subspecialty expertise or more complex thinking expertise from a primary care physician who's used to taking care of the more complex problems presented in a primary care clinic. And then all of a sudden, actually, patients are getting much better care infinitely closer to home because there's a CVS within 5 miles of everybody in America, give or take.
So what you're saying is, Roy, I'll never turn down a strategic real estate footprint.
Well, I will never turn down a strategic real estate footprint because getting care, the care that people want, the way that they want it, when they want it, how they want it, where they want it.
Yes.
Yeah. And it doesn't matter if it's the location is your computer screen or your local CVS.
Well said.
It's good. It's good for us. That's how I want my care, right? I know that's how everybody wants their care.
David, we were efficient. It was fabulous. I thank you for your time, my friend.
Thank you.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.